Welcome to On the X. This is another episode of Mind Matters, a recurring series focused on mental health and fitness, featuring conversations with Jeff Widenhofer, a licensed VA counselor, former Navy helicopter pilot, and one of the sharpest minds I know on this topic. Today's episode is about PTSD, what it is, what it isn't, what to do about it, and how we can better understand trauma and its impact. Whether you've experienced PTSD directly or are trying to support someone else, this is a conversation grounded in lived experience and clinical insight. So here we go with another installment of Mind Matters with Jeff Widenhofer on the X. With mental health conditions, whatever you want to call them, how do you diagnose these things? Because unlike physical ailments where it's like, oh, you've got a virus, you have this pathogen in you, and we have to eradicate that pathogen, and then you will be healthy, or your body can do it on its own. That's not what's going on here. There's no PTSD virus or something like that. These are conditions, as far as I know, that come about through experience and our responses to experiences that we have. Not to say there might not be sort of biological factors at play, but yeah, talk a little bit just about what makes something a clinical diagnosis, how that works in mental health, but then specifically zero in on PTSD. Like, how do we define this as a condition?
Mental health disorders in our culture come from a big blue, and now it's a little, the latest version is a little more purple, book called the DSM-5. It's called the Diagnostic and Statistical Manual for Mental Disorders. And notice the words there, like we talked about this last time, mental disorders, right? What does mental mean? Because for the most part, a lot of these disorders, especially post-traumatic stress, has to do with our emotional state and the dysregulation that happens. So disorders in that book, the book, the DSM-5, is put together by psychiatrists, the American Psychiatric Association. They get together regularly every some set of years and decide what disorders we need to help people, to identify where people are kind of heading outside of normal human responses to difficulties. And difficulties is a very general word, but with PTSD, we're talking about trauma, and I'll define that in a second. But what the American Psychiatric Association does is they come together and they say, here are the disorders. And for the most part, they're just groupings of, and I put this in my notes here, groupings of normal, innate, but sometimes severe responses to stress. That's certainly what post-traumatic stress disorder is. So now I'll just talk about how it comes about, what trauma is. What that book defines trauma is, it defines it as someone perceives or actually experiences a threat to their life. And that's not just, your life, your breathing and your brain activity, but also parts of our body, our limbs, our skin, our sense of security. That's what trauma is. So when we talk about the diagnosis of post-traumatic stress disorder, it's a grouping of, I'll use the word they use, conditions that happen. And to be diagnosed with anything, certainly PTSD, a clinician who is qualified to do so has to go through the big blue book and basically check boxes. And you have to meet criteria. And of course, all those criteria are going to be unfortunate things that are going on in your life. And I'll pause there. You have any?
So basically there's a checklist of things, right? Where it's like this, and are they all, is that checklist behavior that the person does? Is it things that a type of thing that has happened to them? Is it all of the above?
Well, I'm glad you asked, Chris. I think what I want to do today, I actually want to walk through them all.
Okay, perfect.
It's not that long. But I first want to kind of introduce post-traumatic stress. And I mentioned the definition of trauma. And I just want to talk about how the human system, and that includes all brain and physiological and neurological and organ functioning and system functioning, all that stuff has ways of accommodating for, and I'm going to use a phrase here, unacceptable emotional states. I know it's kind of a heavy topic here, but think about, if you've been to a funeral or something, and then you're at the funeral, and it's a loved one and you miss them and there's crying and there's things going on. And then you go out and grab some fast food afterward. When you're standing in line at the fast food restaurant, hopefully you're not sobbing your face off, right? You have to kind of pull it together, and something inside of you, whether you think you're deciding to or not, it just sort of happens that we just kind of, okay, stop. Crying stops, everything stops, and we pull it together and we order our food and interact with the person in front of us. But there's times when that stuff, those emotional states become so intense that it turns into behaviors that we can't really control or stop or manage to a healthy degree. And when I talk about emotional states, here's some examples: um, fear, anxiety, anger, terror, and grief, right? These are all very painful emotional states. I think every human has experienced that to some degree. So we have this highly developed conscious and subconscious instinct inside of us. It's innate to sometimes avoid all that pain. And I know I'm kind of getting in the weeds a little bit here. We can come back to define this. But when something terrible happens to us or the people around us or a loved one, and that's what the DSM-5 accommodates for. It says, even if you hear about this happening to someone who's a very close person to you, you can get PTSD if you learn that something happened or almost happened to somebody that you know and love and is close to you. That terror, and we've talked before about the sense of survival, right? It's all this protection mechanisms. It's not that someone's going crazy. It's that their system is protecting them and in these states. So that's kind of what we're talking about with PTSD. And I'll go through the list here in a little bit, but do you have any questions on that? Am I making sense, or am I kind of moving
No,
around?
let's just go through the list. Like if you have somebody in your office or whatever, someone's like,
Yeah.
I feel like I have PTSD. What are the boxes you have to check?
So yeah, I like what you said. And by the way, I do this all the time in my office with people. And mostly I do it with people who come in and say, no, I don't have that. They come in and say, I don't know what's going on, but I definitely don't have that. I know the woman today her brother was a Army Ranger in the 90s in the Persian Gulf War. And we laughed about it today. She said, do you remember when I came in and said, I don't have PTSD, my brother does? And so that's why I think going through this list helps. And I want to talk just quickly again with the DSM-5 and with diagnoses. It's important sometimes to talk about how we feel like we can be labeled sometimes. Like sometimes it's not a great feeling to be given a diagnosis, and it adds on to the negativity in our lives. Like, great, now I'm walking around and I'm different everyone because this doctor says I have this and he's making me go to these places. So I really want to normalize this, but also understand, like, it's just what the APA puts together. It's just trying to figure some things out. And when we try to group these conditions together into certain disorders, it helps us clinicians kind of organize how to address it as well. Somebody could come in and just be crying all the time and have all these things going on, and you could say, yeah, you are diagnosed with being a mess, but that doesn't help. So that's why I want to mention that. And I'm really trying today, and this is the first thing I want to say about how we can learn to help people. I'm really trying to normalize post-traumatic stress with this language and say things like, it's just innate, it's instinctual. And that's, if anyone who's listening has experienced this or is around someone who's experienced this or knows someone who might be experiencing something like post-traumatic stress, boy, if you can just not add the pressure on of making them feel different and start learning the language around it and having discussions about, hey, it sounds like you're reacting to this terrible thing that happened like a human would, I think that's important to mention. So I know I'm moving all around here. I'm going to come back to what the DSM-5 says about post-traumatic stress. So the first section, the first criteria is something has had to have happened. Directly experiencing or witnessing or learning about it happening to someone, a close family member or a friend, a threat of death, serious bodily injury, or sexual violence. That's straight out of the DSM-5. So that has had to have happened, you know. A lot of people throw around, you know, oh, that's my PTSD coming in. And yet that's fine. It's all good. You know, nobody's the diagnosis police is not going to find you and fine you. But to be diagnosed, you had to be in a situation where something terrible, threatening has happened or it's been seen. So
Yep.
then the second criteria is there has to be, and this, so think about the phrase post-traumatic stress. Okay. Um, that's what trauma, I just defined what trauma is. Now we're going to talk about what the stress is. Um, so the first thing is associated with that event. There has to be some of the following: intrusive, distressing memories, or dreams, or dissociative reactions. And then the last two are psychological distress. Now we're talking about mental, emotional, internal stress, and physiological distress from cues about the event.
Mhm.
So it's still remembered and it's still experienced and it still affects us. So far, everything I'm saying sounds pretty goddamn normal. If something awful happened to us, yeah, we're
Yep.
going to remember it and we're going to react to stuff that seems similar to it.
So let me go over a couple things, just my thoughts on a few things. The first is, I think I'm never a fan of calling mental health conditions, challenges, diseases. I don't like that because to me, it puts it in this pathology where the only solution is treatment of some
Yeah.
kind. It's a very passive, it puts you in this passive mentality of, well, someone needs to fix me or something needs to fix me. And I always like the idea of of empowering people. You have agency over these things, whatever it may be. You might be in a very serious condition that absolutely needs treatment. I'm not saying that, but that doesn't mean you have no agency over the whole thing. Like you always have things that you can do as well, just like you can with physical health. So I say that because there are some people who rail against the term disorder. I've seen
Yeah.
that before where it's like, don't call it a disorder.
Yeah.
And I'm not sure where that comes from exactly, because in my mind, I actually, of all the terms you could use, I kind of like that because it's seems appropriate. It's a pattern of behavior that is disordered, that is not
Yeah.
doing the right thing. And to me, that's empowering as well. It's like, okay, it's a pattern of behavior. You can change that pattern of behavior. We can change that pattern of behavior. So I happen to like that. What's your take on that? And have you had that pushback on that term specifically, disorder, at all?
Yeah. Yeah. I think when I was going through graduate school, it was really pushed to not really not ever use this as a label. That's the big
Mm,
problematic word. And maybe Chris, somebody like you who has really come to terms with what's going on and spent a lot of time looking at it, reflecting on it, and just seeing the reality of it. Maybe in that case, in cases like that, it can help because then now I can
yeah.
see what's going on. And like I said, it's a collection of conditions. It's not everything.
Yeah.
But now you can say, hey, let's address this in my life and let's have some kind of agency with it. But
Right.
there
Yeah.
are there's people that will be given a disorder, a diagnosis of a disorder, and it can lead, just having that disorder can lead to further negative thought. And I'll talk
Mm,
particularly about, like, think about the teenage population. If every 16-year-old goes into a therapist's office and is given a major depressive disorder and anxiety and body dysmorphia, then what's that going to do to them as their brains are developing and growing? And certainly at that age, identity is really starting to be developed. And I think that's, maybe I'll clue in on that. That's where the problem can really come in, is when we identify with a disorder. Similar to
mm,
if somebody has some kind of cancer, and then that's all they see them as. If
right.
that starts to fill out higher percentages of their internal identity. Oh, I can't do that because I'm a cancer. Oh, nice to meet you. I'm a cancer, patient. No, I've got cancer. I'm Jeff. I've got cancer. If it's not like we're trying to deny it. but there's also a really healthy, there's healthy work to be done in our lives to see ourselves holistically and as positive things so we can engage in more positive and holistic things too. Does that make sense?
Yeah, it does. It's just, it's one of these things that I find to be such a, an irony, which is a lot of mental health things like PTSD can be thought of as sort of
Yeah.
illnesses. But again, it's not an it's not like a disease
Yeah.
in my mind. I don't like that term because it's not like you can walk by somebody or be in a room with people and catch PTSD or something like that, right? Where you can catch it cold or the flu where you didn't do anything other than you were in the wrong place, wrong time, and you just breathed in
Yeah.
the flu virus or however that works exactly, physiologically, biologically, and you got the flu. And it's like not really your fault. And you don't feel guilty about that. And but it's something typically, again, like you might have to have some medicine or something like that. So I don't like it. I don't like the mental conditions being plugged into that. But then there's this weird thing where we feel guilty about them too, to your point, where it's like people are sort of ashamed about
Yeah.
these things, right? Um, and maybe that is because, so again, it's this weird thing where you kind of label them as an illness, but they're also your fault. And so you got kind of the worst of both worlds in a lot of times because of stigma there. And I really try to do things to sort of break us out of that, to say, I actually, again, I like the term disorder. It's like, hey, that's just a pattern of behavior.
Yeah.
And you, that's something you can change. And to your point, that pattern that you may have developed for whatever reason is nothing to be ashamed about. Like at the same time, you should be like, okay, maybe there are things that you are doing to probably keep this going that we need to change, but that doesn't mean it's not a normal reaction or something that doesn't happen to tons of people, or like, you shouldn't feel bad
So
about
I
that,
agree with
which
you
I think is a
wholeheartedly, but
challenge.
what you said there, people shouldn't be ashamed. The fact is that we are, when we start working different from society, or what we think society is or should be, uh, real feelings of negativity can come in there. So it's just a lot easier said than done to tell somebody you shouldn't be ashamed of
Yep.
it. You should take on this
For
disorder.
sure.
Yeah, and so that's
Yeah.
part of the work I that I take very seriously when I'm working with someone and there's a clear diagnosis. I want to have these discussions about it too. And you mentioned that phrase mental illness. That's funny. Like, I think that's what I'm kind of railing against here, but I honestly haven't seen that word illness in my work in a long time. It's funny. I'm glad.
That's
It's a
good.
good thing because it's kind of absurd, right? Anxiety
It's
is,
totally absurd.
you could look at it as an illness,
Yep.
as in this, your system's not working as healthy as it could. But we use the word illness in areas where there's clear, sort of noticeable, measurable symptoms in the physiological space.
Yeah. Yeah. But people still latch onto that,
Yeah.
man. I mean, even people that they might have severe depression or something like that. And I've heard people in some of these books over here say, and I was sick. I am sick. And I kind of cringe at that. I
Yeah.
go, I know what you're saying, but I'm not sure it's helpful. Okay. So let's stick on the PTSD component of this.
Yeah.
So you've got those kind of criteria: traumatic event, you've got the kind of intrusive thoughts. And the whole point is, you've got this situation that's just keeps going on.
Yeah.
How much of that too is, I break this down into there's kind of a thought problem, a storytelling problem, intellectual problem, whatever you want to call that, like the sort of the intellectual energy of it, the things I'm thinking about the situation, and then the emotional component of it as well, the kind of emotional energy. As much as we want to separate those into two different things, not they aren't necessarily, but I think in our society, our culture, it helps to do that because we tend to think of those things as two different things. And I think that those two components are very important to look at individually. Is that consistent with kind of the way you look at it as well, and the way is treated as kind of those two
Oh yeah,
pieces of it?
for sure. Yeah. But first recognize, like, if someone comes in and they're got all these negative thoughts and they have the mood that accompanies a lot of time and negativity, like, we can't talk them out of it. So it's you kind of have to be thoughtful on when you use the intellectual stuff and the emotional stuff and the system regulating stuff like the breathing
Yep.
exercises, the meditation, the mindfulness exercises. I think what you're onto is that it of course it all works best when it's all being addressed kind of in the same flow in somebody's life. Rather, I mean,
Yeah.
I'm not gonna refer someone to a class, if they have PTSD.
Mhm.
That's as a fix. That's not it.
We often hear like PTSD is obviously associated with veterans, with the military, with combat a lot. Certainly in your line of work, I'm assuming that's a lot of it. But you also talk about you have sexual assault victims that have PTSD as
Yeah.
well. In the context of the military, is it is the condition an evolution or just a renaming of what used to be shell shocked, battle fatigue? Is it just an evolution of that? Is that all just the same
I
thing?
think so. Yeah. Yeah. So there was the
Okay.
shell shock when that I think that was like World War I, and there's
Something like that. Yeah, I think that's
a
right.
1,000-yard stare. I've heard Vietnam veterans say that that's what they used to be told they had. And battle fatigue. It's funny. This a couple days ago, we're in a staff meeting, and somebody found a book in the office that was a 40-year-old book from when the vet center started, and there was a little
Yep.
3-page, tiny little like, pamphlet on battle fatigue, and it had cartoon drawings. It was clearly like a just an introductory, publication for people to start to learn about it. Yeah, I think so. Battle fatigue is an interesting phrase, but there's a lot more to it, and it's not just, of course, not just battle. First responders
Right.
are really, of course, very much prone to some kind of post-traumatic stress. People who are in car accidents or any kind of accidents, or people who just live in neighborhoods with violence or homes with violence
Yep.
are prone to experience the stress long after the event. That's why it's called post.
Right. So let's talk about then what are there factors that influence why someone might develop this condition? And again, I really like even the thing like have PTSD to me is sometimes challenging. It's like have anxiety again. To me, it sounds like something you caught somehow. It's more
Yeah.
like you developed
Yeah.
PTSD or you developed whatever the condition is. And that's again not pointing fingers or assigning blame, but I think that's important because something you develop, you can undevelop. Something that you end up doing over time, you can undo or you can change. But are there factors at play that make someone more prone to it? Because two people could witness or have essentially the same thing done to them, and one person could develop post traumatic
Yeah.
stress and another won't for whatever
Yeah.
reason. So, are there factors at play that we know about that might make someone more prone to it and someone less prone to it?
Yeah, and I can speak to some of that, but not much. I mean, I'm sure there's people out there who are doing studies on human development that can maybe speak to some of that more. But there's a phrase out there called complex PTSD. Have you heard of that?
Mm-mm.
It's all
No.
it is it's basically if you have multiple points in your life where you experience traumatic
Got it.
events. For example, a kid who's got physical abuse growing up, if he's being hit, if he's being punished, he's being neglected, if he's being locked in a closet, then that kid goes and becomes a first responder, an EMT, and comes across a scene. All this stuff and the emotional dysregulation or the extreme compartmentalization, which was what we talked about last time, like the locking down of emotions, can really start to compound. And now healing our way out of it, it's not just talking about one event, it's talking about a series of events. And that's where the term complex comes from. But you're also
Hmm.
what you're asking here about other precipitating factors, maybe. It's hard to say if for me to say if there are or are not. But
Hmm.
I've seen the studies, and I know you've read some of these books, like Sebastian Junger's his old book Tribe. He talks about
Yeah.
the need to be in communities and how powerful it
Yep.
is. And it's not just a neighborhood of people who are meeting all the time and going to events and raising their hands together. It's about just family, it's about friends. It's also about getting out and being with groups of people and being able to be honest about how stressful it is. I remember that I still remember reading the first time I read that book a long time ago, and he's talking about in London in World War II with the bombings in London, the number of cases coming into whatever the clinicians were called, I think, doctors' offices, the number of cases of reported, I think, anxiety or it might have been depression started to really go down while those bombings were going on. And
Yes.
whoever studied it attributed to like these people really, I'll just use the phrase, came together.
Yep.
So so maybe coming into it, if somebody doesn't have that kind of help already in their life immediately after, especially, yeah, maybe that's a big part of it too. Why it
Yeah.
goes untreated.
How much of PTSD is conscious versus unconscious or subconscious?
Oh boy.
Because you talk about the sort of intrusive thoughts, which to me is pretty conscious. We sort of know, I'll speak from my own experience, my own version of PTSD that I went through. There was definitely a conscious element to it, a story that I told, an experience that I relived
Yeah.
over and over and over and over again on a daily basis for 12 years or so. And it was really the story around the experience. It wasn't necessarily the experience itself, but it was what I was telling myself about it that was the problem. I wasn't conscious of that difference for a long time, but I was certainly conscious of what was going on in my head in terms of the experience, right? The version of the experience. But then there was an unconscious element to it, the emotional energy, the kind of the storage of that I really was not tracking on at all. It had no clue. So how much of, I mean, let's talk about maybe the people that you see. What's the balance there from that? How many people are kind of come in and they say, yeah, I keep thinking about this thing over and over. I keep ruminating on this situation over and over. And how much of it is that? And then how much of it is after a while you figure out, oh my gosh, I've got all this stored emotional energy as well.
I'd say I maybe exaggerate a little bit, but I'm gonna say it's pretty close to 100% people have both going on. You know,
Okay.
they have some conscious awareness of it because they've driven and walked into a therapist's office to address it. So there's some awareness.
Yeah.
But yeah, in almost all cases, there's still a lot to learn. I mean,
Yeah.
months and maybe years of really learning. Oh my God, like that thing I used to do that would mess up this situation, like years later, people are still having these realizations.
Do you think there's a piece to it of why we may end up in these scenarios that's based on the fact that we don't process it in the moment or right after meaning I think a lot of these situations, let's talk about combat, we don't talk about it right after it happens
Yeah.
in healthy ways, I don't
Yeah.
think. You mentioned the community aspect there. I often think of kind of days of the Vikings, right? Days of yore, warrior
Yeah.
cultures, where this is probably a little bit Hollywood, but my interpretation or feeling on those types of situations was if they had combat battle, they then sort of the victors, anybody who was left over, like got together and they had a big party and they buried the dead and they drank and they told stories and there was like a big sort of community catharsis that happened
Yeah.
afterwards. Now maybe those people had PTSD as well, but I always think about their ability to do that where it wasn't like, nope, just go back on the next mission, go on to the next mission. Like, yep, just debrief real quick and on to the next thing. Keep it very intellectualized. Don't emotionally process any of this, just on to the next thing. What do you think about that? Because I
I
feel
think
like
I
we
think
could do
you
better.
just described every single veteran and firefighter that I meet with. Firefighters too. I
Yeah.
got a meeting right now with a couple of guys who are veterans and then served 20, 30 years in fire departments. And they say the same thing. Yeah. You
Yeah.
might in the group room, you might talk about a little bit, but you're not going through a ceremony where, okay,
Right.
everybody, we're going to address this stuff. I'm going to talk about it and you're going to sit there and think about it and we're all going to feel it together and we're going to mourn and grieve. And I use the word process, which
Yes.
like, that's what all that stuff is.
It is
And
totally. Yep.
I'm sure you can relate to it, man. Like being overseas and going through combat operations. Yeah, you don't, number one, don't have time, but nor is the inclination there among anybody really. Like, hey, everybody, let's all come, guys, come on, let's get together and have a big cry. We're
Yeah.
laughing at because
Yeah.
it's so absurd in that culture, and other first
Yeah.
responder cultures too.
Yeah. It's just one of those things that I don't know the right answer of how to do that appropriately, because it's also a thing where you don't want everybody getting fall down drunk on overseas uh, on deployment. But I could see the value certainly of a couple of drinks and that and how that can kind of let your guard
Yeah.
down. And again, it allows you to kind of
And
like
talk
open up
too.
and
Not talk about all the
yes,
other
yeah,
stuff that, remember back in
yeah,
boot camp when this guy was such a dumbass and, no, 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 no,
right,
fellas. Like,
yeah,
what about what happened this morning or
yeah,
yesterday? What about,
yeah, yeah,
yeah. And
yeah.
think what
Okay, so
memorial services are too, right? The funeral
yeah,
services, memorial services can be so important. And I don't know that DOD has a inclination to bring that stuff into their work. They kind of leave it for the outside. That's the politicians can do.
yeah,
VA can do that. The nonprofits can do that.
yeah. But even that kind of thing, I think, can be so formal
Yeah.
and structured, and I feel
But
like certainly in tight knit groups like that, we need the ability to just be like, hey, everybody just completely be yourself here. There's no formality. You don't have a uniform on. Like, just we're going to talk, we're going to feel, we're going to reminisce, we're going to honor all of that. I think we could do a lot better. Okay, we're not going to solve
Nope.
that on this podcast, certainly. So let's talk about when people get to the point where they're in your office and we're trying to address this. Where do you start?
Ooh. Depends on where do I start? I just want them to start talking. I mentioned this last
Okay.
time. They got to start. They got to start acknowledging both what they're experiencing and what happened. And they don't have to tell me all the details of what happened right away. That's probably not going to happen in all cases. It's just the trust hasn't developed. But they've got to just start validating their experiences so they can actually go through the process of feeling it, of seeing how real it is, how they're affected. And eventually, I'm moving faster even down the road, eventually start talking about, okay, so what else do you want then? What else could this be? Because like you said, this is not an illness. You're not stuck with a disease. It's not a tumor that we can see and measure. This is
Right.
your life. What else do you need? That's a question I ask a lot, who do you need to be around? I asked that question at a group today, who in your life, I asked the question basically, are you all, therapy is I hope a great experience for you all, but are you all also turning out to your lives now and identifying the places where you can do these things and be yourself and talk about these things? And that's community. That's coming back to that
Mm-hmm.
concept.
I know a lot of the work you have to do is talk therapy, but do you recommend, or even outside of your practice, are there things that you would recommend to people if it wasn't, you can't necessarily do it through the VA, but but other things that you think could be effective here? Because there's a whole bunch of tools that I think can be effective from a rewriting, like a storytelling sort of rewrite, a reframing type exercises. And I think there's a lot of emotional energy work that can be done here too, on top of just allowing yourself to cry. I can't tell you the number of people I know that are combat veterans that through whatever therapy they did, whether it's some kind of talk therapy or they went and did psychedelics or they did something else, EMDR is another one that I'm a big fan of. I think can be really effective. That was really effective for me. But the number of them, myself included, who needed to cry out, I don't even know how much energy, like suppressed emotional energy. I mean, like hours of it, you know? And so, yeah, other thoughts, I guess, in
Yeah,
terms of
I
what
think the
people
question you asked is, there are other
feel.
things that we can refer people to,
Yeah.
and yeah, but in my office, I'm trying to take care of a lot of that. I'm trying to take care of the talking through and the learning about, and also the acknowledgement of what's happening and the emotional processing too. I keep 2 boxes of tissue on either side of that little couch across from me.
Yeah.
Um, some people get angry. Some people raise their
Yeah, sure.
voice and see as they're telling stories. But as far as what else to do, I mean, there is so much out there. There's a lot of medical, you know, a lot of medical treatments. There's a lot of nonprofit treatments, and you're probably more in touch with that world than I
Yeah,
am. I'm just,
sure.
I got my 40 hours a week that I gotta be meeting with people and doing this work. And I'm kind of, that's where my focus is right now. So I'm trying to hit all the intellectual and the psycho and the emotional and the cognitive and the physiological stuff in my office.
Yep. Do you help people reframe the storytelling component
Yeah,
of
you
this at
mentioned that
all?
the storytelling, and some people call that narrative therapy. That's a
Sure.
phrase. Yeah, all the time, all the
Okay.
time. There was a group I did recently. I wrote the word on the whiteboard, victim, and I said, just
Mm,
turned around and slowly said, "What do y'all think of that word?" And man, the anger, the like, people did not like that word in that group, and they expressed it, but they also acknowledged maybe this is something I could actually come more in touch with. Like, being a victim sometimes has to do with losing control. We don't like that. And a lot of that is intellectual work. I think it's really intuitive for most people. Like, did you decide to plant that IED? Asking if I, sometimes people just don't ask those questions because they can't, because they're so upset, so much guilt. If I would have done this, if I wouldn't
yeah.
have sent the guy over there, if we wouldn't have taken this route. So people just don't, they're not in the headspace. They're not in the calm state, the soothed, grounded state to ask those questions. Did you, um, you know, just decide what the target was that day? Yeah, you pulled the trigger, but is that part of the job? Did you know this person had this thing going on? Did you know the area had this? Did you know the fire would capitulate and escalate to that point in that particular room? And so it's really easy stuff when you and I sit here and talk about it. It's really intuitive and makes a lot of
Yeah.
sense, logical sense. Hard to go
Yeah.
there though.
Oh, for sure. I just think of, by the way, does the VA do any EMDR
Yeah,
at this
yeah, people do
point?
it in my office.
You do.
Yeah, I'm not certain
They do it in your office.
yet. Yeah, yeah,
My experience with it, I did a couple sessions with a licensed therapist on it, and I can't remember what it stands for. It's eye movement, something or other. But it is a therapy where you hold a paddle in each hand, and then you wear headphones, and they have a tone that goes back and forth between the two headphones, and that corresponds to each paddle vibrating. So like the paddle in your left hand will vibrate. It corresponds to a tone in your left ear, and it goes back and forth. And then you can do it with lights as well, where your eyes go back and forth and follow these lights. I actually did it without that. I just kept my eyes closed the whole time. The guy
yeah.
who did it with me said basically he didn't feel like the lights helped all that much. And the ones, he'd been doing it for a while. It was just like, hey, I stopped doing the lights. It just didn't seem to matter all that much. And it also, in his estimation, helped you more focus on your mind if your eyes were closed and you had an eye shade on, and you could kind of spend more of your attention, more of your focus on what was going on internally. And anyway, he had me just kind of conjure up this memory that was bothering me. It had been bothering me for a decade or more. And he said, okay, what are you telling yourself about this memory? And I had to verbalize this story. And then he said, I'm trying to remember the exact order, but at some point he was like, okay, just follow your mind wherever it goes. And you just kind of like pay attention to wherever your mind goes, all these weird places. And he would check in every minute or something. I don't know exactly what the time period. Okay, where are you now? Where are you now? And then he would go back to the memory. And then it turned into, at some point, okay, what story do you want to tell yourself about this? Which was hard because I was like, I don't know what I want to tell myself. I didn't know I had a choice really in the matter. And that was kind of the aha for me was, I had a choice in the story I was telling. It wasn't going to change the event, or at least how I remembered the event. It wasn't going to change any of that, but I could change the interpretation of it. To your point,
Yeah.
something where somebody was involved in an IED. Yes, that event is horrific. And obviously there's the sorrow of the loss there and all of that. But you said it there, somebody saying, and it's my fault, is the story component of that. That is the thing we have to change, right? That's an interpretation
Yeah.
of it. That's not what happened. And for me, I think I did 2 sessions of that, and it completely changed. It's like the memory's still there. I just don't think about it the same way anymore. And the thing that I have other things that in the past bothered me from a memory standpoint, from I don't know about PTSD, but things that would come up and I'd ruminate on. Well, what that therapy did for me was just made me realize, well, I could do that with anything. I don't need to
Yeah.
necessarily go through EMDR. I could just change the story I'm telling myself. Why don't I tell a different story? No one's forcing me to tell this story. That's easier said than done, for sure. But it was a big eye opener. The other one is this kind of memory journaling practice where Andrew Huberman talks about this on Huberman Lab, and there's a whole bunch of data and studies behind this where you spend 15 minutes, whatever your worst memory is, like worst thing that's ever happened to you in your life, and you just write about it for 15 minutes, as much detail as you can, how it made you feel, what you think about it, anything associated with it, just write it all down, and you just leave it. And then you come back to that 3 more times. So 4 writing sessions, which can be, I think, any 4 days within the course of a month. They could be 4 days in a row. They could be every week. Doesn't really matter. And you just do the exact same exercise. And there's something about doing that that helps you process the experience, whether it's the externalizing, and the word choices will actually change over time too. So if you go back and you review it, your interpretation of it will change to the, even if slightly, to the positive, where you just don't, it's not as heavy anymore. And that's another like really simple thing that I think people can do just from the sort of intellectual component of this to sort of alter the story they may be telling about
You're right.
themselves.
And but it has to get to the point where you are able to not be so bothered by it. So where you can sit down with it. And this is what EMDR is addressing. That the DR is desensitization, reprocessing. So first off, desensitizing, like I'm going to help you sit down and tell this story. We're going to get through it, because a lot of times, like some of these memories we have, like as soon as it starts to come up, like, oh, I'm not thinking about that. We just, consciously, subconsciously choke that off and try to move on to something else. That's the compartmentalization.
Yes.
And then
that's the suppression component.
And then the reprocessing is what you did there. Reprocessing the memory. Because there's all kinds of data in that memory that says, yeah, you are not at fault and you are not the cause of doing all these things, but your emotional attachment to some of that is the call it a problem. That's the dysfunction, and it causes the dysregulation, the guilt that you feel, the anger you feel, the sadness, the depression, and all stuff that follows. That's the problem. And it's built on this false sense, right, of what happened. It's a sense of what happened. It's not the facts. So it helps us get to the facts. That's where it can really be helpful.
Yes. Yeah, 100%. That's really interesting. I hadn't thought about it in that context in terms of it can be that hard to get through it because of the emotional suppression that's going on. But you're 100% right. For me, those things were somewhat separated, I guess. Like I could get through that story and tell it. I mean, it didn't make me comfortable, but it wasn't going to stop me in my tracks. But I do think that if you found yourself in that situation, I think that's a circumstance where you have to go, okay, cool. Like if it's that hard to get through, because again, you're trying to choke down the emotion component of it. Okay, stop. And now you got to be able to let that go, like let that out so that you can get through it. Right. And if it's like, hey, you can only get through a sentence until you're going to start bawling, but you're not allowing yourself to go there. Okay. Well, the first step then is you got to let yourself, you got to go there.
That's right.
Like let it out. And if that takes a while, if you have to do that 10 times before you can get to the next sentence, great.
Yeah.
Like, let's do that,
And you got to the point where you can do that in all kinds of
Mhm.
ways then, probably through some work and some effort and some things that helped get you there. But you're right. Now
Interesting.
you don't need an EMDR licensed therapist. You don't need a light fixture in front of you or whatever the paddles and the clicking and all that stuff is. You can sit down with your journal tonight, tomorrow morning, and start writing it out and actually feeling all the tension around this thing to happen. And the process of writing out helps you learn to live with it a little bit better.
Yeah.
So I want to say what I said on the last episode I was here. Like a lot of this stuff is it is intuitive. it's science in a way, and it's studied, and we try to put it into programs. And like what Huberman did there, try to get those sessions. That's a good way to get it organized and to help someone feel
Yeah.
like, oh, I can do this if it's just this. But he's just talking about, just talk it out on paper.
Thanks for listening to On the X, the official podcast of the Navy SEAL Foundation and an IRONCLAD original series. Learn more at NavySEALFoundation.org or text On the X to 60104. Please like, share, and subscribe. See you next time.